Professor Jair Soares from the United States. Thank you very much for waiting for your time, because we had some difficulties with connections at the beginning. And the lecture of Professor Jair Soares will be devoted to the translational neurosciences in clinical practice, focus on mood disorders. But I would like to say a few words introducing Professor Jair Soares, who is the director of the Center of Excellence on Mood Disorders in the University of Texas, and also have many other affiliations. Professor Jair Soares is the leading expert on mood disorders and has published more than 200 peer-reviewed papers. He received his medical degree in São Paulo in Brazil, and then had his residency in adult psychiatry in the Western Psychiatric Institute and Clinic in the University of Pittsburgh. And then he also worked in the United States and working on mood disorders, and received numerous honors and awards, including the Best Doctor Award. And also Professor Jair Soares is co-editor-in-chief of the Journal of Affective Disorders. So we are very honored to have you in our agenda, in our webinar. Thank you so much for joining us. You are very welcome to the stage, Professor Jair Soares.
Thank you very much. Good afternoon. I'm honored to be here today. So what I will do over the next, I guess, 50 minutes is to give you a brief overview for how some of the translational research in neurosciences can bear upon our understanding of depression, and hopefully translate into better treatments for our patients, and tools that we can apply to our clinical practice. Just get the... Okay, good. I was... well, I just want to start by showing you my professional home here in Houston, and we are part of University of Texas, and have a growing Department of Psychiatry with now about 110 full-time faculty members. And it's a combination of clinical programs, some educational efforts, as well as growing research programs as well. So depression is a, very, I guess, complex syndrome, and by not knowing the mechanisms, we don't call those illnesses. We refer to them as disorders, as you guys know. What I want to illustrate with this slide is that it does have this interface with a whole array of physical problems, medical problems, including diabetes, obesity, research that more and more demonstrate that these patients have some cognitive impairment that in many of those, it seems to persist even when the depression remits, primarily in more chronic patients that have had several episodes, cause a lot of disability, has some interface with cancer, increased mortality, heart disease. And obviously, I guess to some extent, chronic depression could, I guess, be a risk factor to some of these problems, but also it makes the outcomes worse. As we know, as we clinicians know, if we have patients, for example, who have heart problems, if in the aftermath of their heart problem, they develop depression that is not recognized, that is not treated, that tends to lead to worse outcomes for their physical problems as well. So that's information that we've had for a while, and the evidence keeps growing. What causes depression? That's, I guess, the million-dollar question, and we do know that there are certainly some biological influences, like genetic predisposition. We know that because it runs in families. there are detectable changes in brain anatomy, function, connectivity, some aspects of neurochemistry as well that can be elicited, documented with neuroimaging. We also know that it has something to do with one's personality and I guess baseline functioning. You know, how people deal with the stress, how they approach their interpersonal relationships. There are some gender differences as well. It tends to be more prevalent in females than males. And also has to do with social and cultural factors. Obviously, you know, in times when there's more stress and more trauma, the prevalence of depression goes higher. You know, that's another known factor there too. So after 4 decades of trying to look into the biological mechanism, the neurobiology of this constellation of, signs and symptoms that we call depression, you know, our field is trying to take a little out of the box view at the problem. And, you know, we've seen research efforts more recently where people, you know, are trying to pick certain domains amongst all the symptoms that a patient with depression has. For example, like anhedonia is one. You know, anxiety is also that it's a symptom that's very prevalent in individuals with depression. I mean, we know there is a lot of overlap. So we are seeing more and more attempts to go across these dimensions and try to look into the neurobiology underlying them, rather than just, you know, look for the neurobiological underpinnings of depression per se. And you know, this is moving along. I mean, you guys have all heard about this RDoC, Research Domain Criteria, which is a research initiative that the National Institute of Health here in the United States started, you know, some years back. You know, no final answers, just the hope that perhaps by looking across different domains, we will be better able to understand the neurobiology than looking into this complex construct, which is depression, clinical depression. You know, there's some hope, lots of questions, very few answers still. Over the years, we've seen a variety of theories to explain, you know, how depression comes about, and looking into monoamine imbalances is a very important part of it, and it led to several of the antidepressants that we have currently. I mean, we know that modulation of serotonin, dopamine, norepinephrine, that's an avenue to improve depressive symptoms. And those are the basis of many of the medications that we have approved now and that we use, you know, in our clinical practice. And people have started, I mean, obviously there are other angles to look, and these neurotransmitter pathways in the brain, they are very interrelated. So it makes a lot of sense to look into other neurotransmitter pathways. For example, you know, glutamatergic pathways and NMDA receptors. That's been an area of great interest recently, and we've seen that in the talk by Professor Hassler, you know, just before my lecture here. We do know that these patients have neuroendocrine abnormalities, and those seem to be noise-specific. There's been a lot of research. Unfortunately, nothing that panned out as a diagnostic marker or a viable tool to best match patients with certain treatments or to track the course of treatment. But they do have, those are, you know, subtle and noise-specific, a lot like the brain imaging changes, you know, that we find, and we'll talk. I have a few slides about that. More recently, we've seen interest in neuroinflammation, which, you know, there is some level of systemic neuroinflammation, probably stress-induced, that might be affecting the brain. and be leading to some of the brain changes that these patients have and develop, over multiple episodes. So that's an interesting theory. Disappointingly, attempts to try to modulate these inflammation levels to improve depressive symptoms haven't really been successful. But again, it's still mostly smaller trials, and perhaps it has something to do with the timing as well, where, if one already has a lot of involvement in the brain, one could think that perhaps going early and preventing that inflammation from taking place might be a more fruitful way to treat it. But again, nothing based on data. It's just theory and hope at this point. Another important theory has been that neurotrophic factors, perhaps regionally in some of these portions of the brain that modulate emotion, that we broadly call frontolimbic brain circuits, that perhaps some abnormalities in the levels of neurotrophins, like, for example, BDNF, brain-derived neurotrophic factor, that could lead to some local atrophy or damage, that may compromise the functioning of these interrelated circuits and lead to the symptoms of depression. So that's kind of like where we are as far as trying to develop a good theory, a good hypothesis that might explain some of the cases. And that's another important point. This is probably not uniform. One should think that there are different subtypes where different types of biological mechanisms might be involved. This next slide is just an outline of neurotrophic pathways in the neurons, and illustrates what I was talking about, the thinking that perhaps abnormalities in the level of factors like BDNF may end up, being key steps in the neuronal damage that takes place, and the pathophysiology and the symptoms that develop afterwards. So that's an interesting theory that's being explored. A very important limitation has to do with access, where it's not like other organs of our body that are more external, where one can more safely do a biopsy. I mean, obviously, you don't want to biopsy the brain to test, the theories and the pathophysiology. So that really limits our ability to test, these specific steps. The best we've got is really the tools that Professor Buchsbaum has developed over the years, PET scans and ligands. They are getting better, but still, by and large, not specific enough. Like, for example, if you look for markers of inflammation, yeah, there are some. They aren't perfect. And again, it's an evolving story, but a lot more questions than answers, for sure, and nothing that is nowhere close to helping us, in clinical practice at this point, in my assessment. It's different than the dementia story is a little different. I'm talking about, depression here. So then on the lines that inflammatory mechanisms might be involved, there is also a hypothesis that perhaps immune mechanisms, and some of that could be related to, our gut and exposure to different types of food and bacteria in our gut, and that could trigger certain immune pathways and mechanisms that might lead to, some level of brain damage and impairment that might lead to mood disorders. Again, total theory at this point, and some active research that happens, but this needs to be properly investigated. But it is an exciting avenue, and it's great to see efforts to try to test that. We talked about frontolimbic brain circuits, and this is just an illustration of some of the key brain areas that are involved in these circuits in the anterior portion primarily of the cingulate cortex, illustrated here. Then amygdala, hippocampus, those are all important areas of interrelated circuits that have been extensively examined and tested for their potential involvement in the pathophysiology of mood disorders. And this is again an outline here to show some of these interrelated circuits and illustrating other portions of the prefrontal cortex, orbital frontal cortex here, and these pathways that I guess go through the thalamus onto the medial temporal lobe, like amygdala, hippocampus. A lot of research over the past 3 decades showing that not only functional changes, but also anatomical changes in size, shape, as well as connectivity. That's an active area of research, and it's been shown beyond doubt that there are abnormalities. The key here is that the changes that have been shown are generally noise-specific, and in many instances hard to replicate. Attempts to try to link these circuits with treatment response haven't really been, successful. So there's hope that perhaps understanding these circuits may help us best match patients to certain treatments, understand when depression comes about. Very active area of research ongoing, but a lot more questions still than any final answers, and unfortunately lots of non-replication. This is an illustration from our own work, and we've known now, several have replicated this, where some hyperactivation in the amygdala in patients with depression that's not medication related. In most studies, it's actually bilateral. In our study here, for statistical significance was just unilateral change. But in most other studies, well, there's a kind of a trend on both sides here. But in most studies, you will see this replication bilaterally. And there are some limitations on the paradigms too. So this is just showing faces that depict certain emotions and asking people to label the emotion, like sad, angry, neutral, and any people, any healthy individual, mentally healthy individual who engages in that, the amygdala will be tapped on to perform that task. And the issue is that when you compare that with in patients with depression compared to healthy controls, you will see that the depressed people, the amygdala will be hyper responsive. They will have to, it activates more as they perform the same task. Then Dr. Mayberg, who has been a pioneer in this area, this is work, her work from now, I guess more than 2 decades ago. In a small, simple, she tried to link activation in the subgenual, I guess, rostral portion of the anterior cingulate. And, she found some differences in activation between responders and non-responders. But this, it's often hard to replicate. And again, this is just a small sample, but it's compelling, it is interesting. And but the realization that, despite all the research that we've done in this area, none of us has come up with anything that is helpful in clinical practice yet. So, our work remains to be done. It's the challenges are still there ahead of us. Well, if it serves as any consolation, my career has been done mostly with neuroimaging, neurocognitive studies, and clinical trials. I'm not a geneticist, have collaborated with some here in the audience are, but my consolation is that the genetics story is not that different than the story that the neuroimages will tell you, where it's still lots of non-replication, and now these samples have gotten to be very large, like the paper illustrated here. And so my read of this literature from like a recent work done in this area is that attempts to find a common genetic basis for MDD have had limited success. Yes, certain genes and pathways, largely, not replicated, small effects. So nothing that has really changed our understanding of how this comes about, and nothing that has given us any clues for how we can best diagnose or treat it. Now, there is some interest in epigenetic mechanisms, and we are very hopeful that this, will be more fruitful than just looking at the, I guess, a whole genome scanning and analysis. And so the idea here, I mean, obviously, when genes are activated or deactivated, there are some protein changes that take place in the cells, and you can measure many of these processes. And there is a lot of literature showing that they are heavily impacted by stress, perhaps other environmental factors. So there is a great interest and hope that perhaps by elucidating these epigenetic mechanisms, we may come up with tools to inform the pathophysiology of this illness and our approach to preventing and treating these patients, preventing these illnesses and treating these patients. Well, switching gears a little bit, I will submit to you that despite, well, part of it is that we don't know what causes it, don't know the mechanisms involved, and the treatments aren't effective for a sizable number of the patients. But we do have many who can be successfully treated with the treatments we have now. It's antidepressants as well as psychotherapy. Our field has thankfully moved to evidence-based types of psychotherapy, as opposed to more dogmatic approaches where you treat, you don't measure, and then you just hope that maybe someday, years later, they will finally get better. So we are more, interested in shorter term, more focused types of psychotherapy where one can design trials to measure effectiveness. And in treating patients with depression, we've seen, I mean, this is a lot related to how people manage stressors, and then affects sleep, affects appetite. Some people have an dysfunctional interpersonal style where, they keep repeating those same patterns that cause them stress over and over, and they go through life like that. And unless you can really, help them with psychotherapy that will change that, there's little that you can do for them that will last a long term. Antidepressants are not going to fix that. It will give them, improve their moods and, improve the symptoms, may give them a better outlook and a better ability to deal with those situations. But I guess my point, those have to be combined. We have stuff that works, well documented, but despite that, many of our patients don't get it. And that's the slide illustrates exactly that there is so this is like in the US, sort of like regular healthcare settings. In this particular study, half of the patients, were receiving treatment, only half of the people who had depression. And from the ones who received it, only about 38% received what was considered minimally adequate treatment. When you look at the dose, how long they've been on it. So in primary care settings, what we often will see is underdosing and staying on the underdose for extended periods of time, no matter whether the symptoms are still there. So, that's an area where we mental health professionals can and should help. And we're seeing more and more collaboration, attempts to develop what's called like measurement-based care, where you have certain, more objective symptom measurements that are built into what's been collected and looked at, where hopefully it will be easier to detect and will be more responsive to treat these patients with the stuff that we have today that could help many people who are just not receiving it. Now I want to discuss the treatment-resistant cases, and that's a concept that people often debate. You can look through the literature, you find different ways to define it. Most people say if you fail 2 proper antidepressant trials, and proper has to do with dose and also how long people took it. So defining it like that, 20 to 30% of the patients with depression will meet that criteria for treatment refractory depression. And that's the group that causes a big portion of the costs, economical as well as societal costs related to, depression, the illness. We've seen attempts to bring pharmacogenomics to the clinic. And since the markers are not any good for, if you look into genes like SNPs for serotonin system and other related pathways that we know are related to the pathophysiology of depression, none of that seems to pan out consistently as much of a predictor factor. The best that the field has been able to come up with so far is obviously the genotype in the P450 enzymes will tell us about how the body will metabolize certain drugs, like most of the psychiatric drugs we take, they go through the liver and they are metabolized by these liver enzymes. So that way you can tell who are fast metabolizers, slow metabolizers. And there are companies that are marketing panels to do just that. Some colleagues are warmer to those than me. I still think that when you look at the cost and the benefit, most often it doesn't justify. The cost is low for what I consider a modest benefit. Yeah, perhaps we should do it, but high cost, low benefit. That's not something that has compelled me to think that I should do this routinely in my clinic, to the patients that I see. Often also, if you've done some of these tests, you will get a table that will tell you, drugs that the patient is a slow metabolizer, a fast metabolizer, and it color codes and tells you drugs to use, not use, or use with caution. I would submit that, if being a careful clinician and going, slowly with the doses, primarily if people are elderly, that one could accomplish much of what you may get from the test just by, going carefully with how you start the medications, how you raise down. There isn't really compelling data to show that at a healthcare system, or at least a little larger scale, that this will save the healthcare system any money, that we will get better outcomes. It's still developing, but as we have it, I haven't warmed up to it, and many colleagues haven't. And often the medication that will help the patients is the one that is in the red column, the column not to use, perhaps exactly because they are slow metabolizers and you end up getting to a higher dose of the medication, which may cause some side effects, which you monitor, but may also help them better. So I'm still a little bit skeptical of the value for these panels the way we have them today. But we hope they'll get better. Well, last part, I want to tell you, briefly, just give you a peek onto things that are in the horizon, things that are being developed. And this is all experimental stuff. There's no thing that I'm going to talk about here that is approved in part of regular clinical care, with one exception, TMS, you see. Okay, so we have now a greater realization that lifestyle factors have a lot to do with mood and anxiety. A lot of research from the past few years showing that regular exercise improves mood, improves anxiety, improves sleep, lessens systemic inflammation. And so that's really well demonstrated. And that's an important third component of the treatment. So we talked about medications that hopefully will help them, psychotherapies that are needed, And then lifestyle things that the patient has control over and could change, even if gradually. Like, well, I tell my patients, I say, look, the same things that help the body, they'll help the brain. Eating healthier stuff, giving yourself enough sleep, not adding up lots of alcohol and drugs to a brain that is trying to heal, from, I guess, these changes that happen in your brain that we see as the symptoms of depression, as well as regular exercise. That's good for the body, good for the brain, and should be, I consider that the other third, the final third, first medication, second psychotherapy, and then things that one can change in the lifestyle that will benefit the patient's recovery. We've seen, and Professor Hassler gave us a great explanation about, ketamine, and he also talked about psilocybin, some new drugs that are being developed that, in ketamine's case, NMDA receptors is, it's a very dirty drug, but we believe, the prevailing theory is that what it does for NMDA receptors, that's why it will help folks with depression. The injected ketamine helps. There's a lot of data, but there's never going to be a trial to take this to approval because it is a generic drug, very cheap, but often used on an off-label basis based on strong data. Helps, but the effects are not persistent, and then one needs to get these booster injections. And it's unclear, how often, for how long. The research so far seems to show that going through months or a few years, that there have been, in some case series, and I guess patients being followed for a few years on those. And there is really no evidence, credible evidence, that it would lead to any neurotoxicity. They get it in the clinic, so it's not like it's causing them to become addicted to that. So it seems safe and helpful, but the issue is that it requires repeated treatments. Then more recently, we've seen esketamine intranasal becoming approved. And it's an interesting treatment. It's certainly easier to administer than the injections. Question remains as to, is it as efficacious? And and there isn't really data comparing it directly, but some colleagues who have used the intranasal esketamine, they still think that the intravenous injections, might be a little more efficacious. And work needs to be done to look at that, but it is great to have new treatments coming and becoming available for people who may not respond to other more traditional things that we've had and used. And this slide shows that's, like I was saying, glutamatergic pathways are of great interest, and that interest is sparked by the success with ketamine and esketamine. And some different leads here. The one listed Glix13, rapastinel. Yeah, this is not as hot anymore. Apparently, early trials did not pan out, but it is an area of great interest for pharmaceutical development there. Thinking a little more outside the box, perhaps modulating the opiate system might help with TRD. And there are some attempts to do just that. This is an example. It's a combined product with buprenorphine and samidorphan. And, those are drugs that, so buprenorphine is partial mu-opioid agonist, and samidorphan is mu-opioid antagonist. And some early data showing that it might help with depression, but, the jury is out there. There is really no thing final that would tell us that this is, we are not, apparently the latest results weren't as impressive, and the company might have this on a halt right now to decide what to do next. Well, so TMS, neuromodulation, that's another big avenue there to try to treat depression, primarily the more refractory cases. I mean, this is a magnetic stimulation. It's non-invasive, cause very few side effects, but it's time intensive and it ends up being costly. You often have to give 4 to 6 weeks of 5 days a week treatments. The sessions last like 45 minutes. There are some attempts to develop shorter sessions, that might become more time efficient and more cost efficient as well. It does help some patients who have not responded to medications and who are not ready for ECT, which is still, by the way, our gold standard. I mean, it is not something we are proud to admit, but after all this research, the best that we've got for the most severe cases is really our old ECT, which is done under much better conditions these days. It's just another medical procedure. Thankfully, the stigma is changing fast, but it is still the most reliable, the most efficacious for some of our most difficult patients. An investigational tool called TDCS, transcranial direct current stimulation. This is electric stimulation, same as ECT, but not to cause a seizure. And again, it's kind of time intensive and the data is questionable. It's investigational. A few centers around the world doing good work, properly controlled trials. Some early trials that caused excitement and later trials that haven't been as exciting, but the jury's out there and people are trying to work out the right protocols for stimulation as far as like the intensity and the parts of the brain that you target. That's all still out there in development. Last, just want to share some of the work that we are doing here around deep brain stimulation. This involves a collaboration with our Department of Neurosurgery. And obviously, that's something we want to be very careful about. Last time that psychiatrists and neurosurgeons, started doing stuff together, we ended up with lobotomy. So we have this shameful past to contend with. But this is involves the implantation of an electrode to the brain. The device is illustrated here. There's a battery that goes under the chest wall and then a wire, that goes under the muscles in the neck. And then the neurosurgeon drills a hole in the brain and you implant it bilaterally and you can put it, I guess nearly anywhere in the brain where you think there is a good rationale to do that. So this is approved in the United States by the FDA to treat Parkinson's disease when they do not respond to medications. But obviously for Parkinson's, you're going to target, some of the motor dopaminergic, parts of the brain. For mood, Dr. Mayberg, Helen Mayberg, was one of the pioneers here, and they tried, the area that she's been interested in, the subgenual anterior cingulate, and early trials gave us great hope. Later trials weren't successful. There was a multi-site study that was stopped. It was a drug company study, I guess a device manufacturer study. And if you ask her, she'll say, look, that was a failed trial, not a failed target. So she's doing research to try to perfect the matching between, finding the right patients. Perhaps imaging, pre-surgical imaging can help us map the circuits and find the patients where stimulating, implanting the electrode in the subgenual anterior cingulate is the thing to do. So in our case, we've started our study here a few years ago, and we're impressed by the German data generated by Tom Schlepfer, where stimulation is done to a portion of the brain called the medial forebrain bundle. This is our early publication going now, I guess, 4 years ago. Time goes fast. And this is an illustration for, these fascicles that we call, an MFB, medial forebrain bundle, and where the electrode is implanted in one of our patients. And so we tried to mimic as best as we could the protocol that Schlepfer and his colleagues in Germany had put in place. and set out to try to replicate his data. Which we have. For now we've done 11 surgeries, actually 12. We did one just last week. And we have some patients that have been followed now for 2 years or slightly more. And we have the latest compilation. We had 6 patients followed for over 2 years, and the response rates in our range are slightly over 50%. And longer term response, it seems like it takes a few months for you to see that response coming. And there are some concerns that once they respond, if you were to turn off the stimulation, that they may crash fast and not respond as well later. But that remains to be investigated in research. We know that Tom Schlepper and his group, they're working on the next phase of their studies. And in our case, we did the first 10. The data looked very promising. That allowed us to go back to the FDA and convince them to let us do the next 10. So we've done 2 of this new phase of 10. For now, it's still an open study. I mean, we've been reluctant to do an off and on type of design based on data that, perhaps they will crash and not respond. But these are some of the most severely ill patients. We require that they have failed minimum of 3 trials, clinical trials with drugs, that they've gotten proper psychotherapy in play, for a period of time, and that ECT also was not successful for them. So most of these patients have tried everything under the sun. They've tried all medications and combinations and are very impaired. This is just an anecdote. I mean, but we had one of our patients, a good case this was a physician in her 50s who had not worked for 3 years, had attempted suicide a few times, and now she's back working full time. This is not a vaccine against depression. She's still, and once the depression improves, you'll see some dysfunctional elements of the personality that many of these guys have. But still, if you look at how she was doing before and how she's doing now, she's able to work full time. She feels a lot better. And the ratings of depression will show us objectively, that she overall has done a lot better, even though, has some ups and downs, like you'd expect from people with depression. So this is what I had to share, and I will be glad to take any questions if there is time left for that. Thank you so much for your attention.
Dear Professor Jair Soares, thank you very much for your amazing, impressive, motivational lecture. Yes, we're out of time, but one question for you. Just
it's in the chat, or
from Dr. Senat Hasanj from Bosnia. He asks you to comment the statement about memantine blocking glutamate excitotoxicity while stimulating its physiological transmission with anti-inflammatory effects as adjuvant treatment. What can you say about this?
I'm sorry, can you repeat the question? I was trying to read here in the chat and I couldn't find it. Tell me again, what is the question?
Yes, the question, this is the statement, and the question about the statement that the memantine are blocking glutamate excitotoxicity while stimulating its physiological transmission with anti-inflammatory effects as adjuvant treatment. What can you say? What can you comment about this?
Very good point. There is a rationale for trying, and there have been I believe a couple of early trials without much success, but that's, the rationale is compelling, but I don't think the data for the early studies that were done panned out, and that's why I'm not aware of any active effort in trying to test that in a larger scale at this point. But it makes perfect sense for the rationale that you mentioned there.
Thank you very much. And I would like to say that during some small coffee break, I was running directly to Delphi, to the umbilicus of the earth, and asked all gods to that Professor Kostas Fontolakis join us and the internet connection will happen. So Professor Kostas Fontolakis is with us and he wants to say hi to you.
Happy to see you again. I apologize for not being able to be here from the beginning, but everything collapsed.
Well, it happens. It's the new virtual world that we're trying
Yes.
to learn how to navigate. But I'm hoping that next year, this, Greece is a beautiful place in person rather than over the internet is how we want to be talking about these things, isn't
We
it?
will be waiting for you alive next year in June.
Excellent.
In June. Take
Thank you, my
care
friend.
and stay
Appreciate it.
safe. Bye bye.
Take care. Thanks, Daria. Bye-bye.